As Steve alluded, I've been with Memorial quite some time, and started there as a young pharmacist and ended up in the data processing department, which is what it was called back then, and programmed things in languages that are no longer used, and worked my way up in the organization and been the CIO for some period of time. So I'm going to do a flyover of healthcare IT, at least some of the stuff we're working on. I could delve into any one of these subjects as many of you could as well, to explore further, and I'm happy to do that offline. There's so much going on. IT is so pervasive in everything that we do. So I'm just going to try to give you some perspective on it, some thoughts, and how we're approaching things as we really find our way through this. So the program said the IT challenge of population health. I really thought there was more than one, so I added an S with the IT challenges. I'll try to go through some of them going forward. The main themes, the realities of IT today, and really the realities of our business, the opportunities that it presents in the area of population health, where we are and where we're going. And the way I look at it is how are we translating these market forces into specific actions for IT. Some thoughts about IT planning and how we're going about it and how we incorporate innovation into that. And then some thoughts and advice, again, for what they're worth. This is about where we were in 2003. This is a chart that I think I have to give credit to Scott Zabula. We created way back when we were imagining going forward, and we became a system of 4 hospitals, not an integrated delivery system, but it is one of the most compelling charts I think we've ever put together about how not to run a business. And across our 4, well, it was a starting point, and across our 4 facilities we had IT to be sure, but it was quite diverse, and if we were ever going to integrate and take costs out and do everything else, we probably needed to do something. So we spent a decade or so going to this, where the idea was common systems, common processes, common data, and it's harder than you think. And Barry did say we do a lot of things the same way across our system. Not everything, we're getting there, it's a work in progress, but first and foremost, starting out with a rational set of vendors, fewer vendors with whom we have great partnership and we can call upon to help us solve our problems. So we've been rationalizing our systems, and as I'll talk about later, as you get into this population health, we're kind of going backwards to what I would call almost a best-of-breed environment as we find our way through the tools in an immature market, frankly, for population health. So now that we've arrived, this Vi Schaefer's quote, I think she did a thing on a symposium, ER, EMR, EHR alone is neither innovative or all that differentiating. It's table stakes on a go-forward basis. And I think the question is, on the left, all of these things are largely taken for granted. They're assumed, and many of us are still midstream or continuing to optimize our EMR, thinking about what's on the right. Population health, for whatever it means, is more about us taking on risk. In a nutshell, if you think about what the business is, and really to sort of distill down some of what Barry was saying, we want to be more complete in a broader market and more accountable. And that's a 3-minute elevator speech. That's really the transformation going on in our business. And how does that turn out to be translated into IT? What kinds of things do you need for that? How does your identity management, for example, work across multiple organizations? That's about to confront us in this Vivity exercise. So it's all about social mobile cloud and these other kinds of things on the right. So that's what I'm going to kind of talk about going forward. And as I said earlier, it's sort of table stakes. This is Mount Everest. This is kind of the way I've sort of this metaphor for the EMR. We wanted to get to the top, and we knew we needed oxygen. We knew we needed help. We knew we needed a fair amount of good luck. And that's really the journey we've been on, but the idea of the destination was fairly clear. We knew what we wanted to do. There wasn't a whole lot of doubt about it. And then, we make our way to population health, and it's more like this. You can see that first tree out there. It looks like risk management. It looks like identity management. And then you look beyond it, I don't know. We're going to have to find our way. But that literally, to me, is sort of the difference between the two. I don't dare call it a muddle, but I think it is to some degree. We're going to find our way to population health. That's just the way it is. There's no apology there. It's just the business is changing, and we're going to have to figure out how to augment what we have, supplement what we have, and learn to use what we have a little better. When in doubt, always turn to Yogi Berra. Great quotes. The future ain't what it used to be. Again, we got that EMR in, and they paid us. It's like Jack Welch said, you know, I pay you on Friday, on Monday we start over. And I sort of feel like that with regard to population health. We're starting anew. Frankly, it's very challenging and lots of opportunities, but Yogi nailed it in that case. I like the Gartner hype cycle. I'm not going to go into great detail. Many of you are familiar with Gartner. If you look off to the right, that's the EHR. It's all over there. It's not differentiating. This table stakes. It's at the plateau of productivity. Those things largely work. There isn't a whole lot of risk. The question is, where are you in using those tools? If you come up here, you start to see the population health. This is the peak of inflated expectations. I'm sure most of you get emails all day long about the new and wonderful technology that will solve your population health needs. Some of them might actually do that. Some of them may disappear from this curve as they come down into the trough of disillusionment, and we've probably all been there one time or another. And then there's the stuff over here that's really pretty cool, and that's where patient engagement and fancy tools and Fitbits and everything else are, and that do show a whole lot of promise, but they're really early in the curve. This is the point where everyone's quite excited about them, and the real question is how are they going to make their way, will they make their way through this curve, which typically takes 3, 5, maybe as long as 10 years going forward. I like the way the advisory board expresses population health IT. I'm not going to go into great detail. It's another one of our subscriptions. We like the way they think. They took this taxonomy, if you will, of how to look at population health from an IT perspective and said, you know, you got these basic 6 broad categories. What are the basic requirements, and what do the IT solutions look like? And I don't know about you, but that's one of the issues we face is in population health, trying to distill down what are the business requirements that are needed, because it's kind of hard to go shopping for specific IT tools until we know what problem we're trying to solve. And about all you can do is buy the generic stuff. You can buy the identity management, you can buy risk stratification. By and large, those will be decent investments, but to get down to the specifics, it's going to require that we figure out what our business requirements are going forward. They've attempted here to sort of articulate what the obvious ones are, and then as you translate those, what the IT functions are that are going to be needed. This was Wes Rischel's. Goes back to Gartner. I like the guy. He did a number of papers, but the 3 that were done in a row, provider-led, payer-led, care management, where he's talking about the impacts, and he's talking about the top recommendations. And the one comment that he made is provider institutions, that's us, our understanding of our requirements is just about as preliminary as the market offerings are. And again, no apology, that's just what to be expected. There are some out there that have organically grown or supposedly organically grown tools that will all do your population health needs. I think that's to some degree true. We know the big vendors, Cerner, Allscripts, Epic, are all marching into the population health space. It tends to look like analytics at first and then a whole bunch of care management, care coordination tools after that. But by and large, what Wes was saying is that plan on buying some things and maybe throwing some of them away. Shorter depreciation cycles, explaining to governance and others who may be approving these things, which by and large aren't nearly as expensive as what the EMR was, but nevertheless something that we might end up learning from and discarding later on as we get a little smarter about what we want to do. I think the heart of the matter is this, and I'll spend a few minutes on these next 2 or 3 slides, because if you think about this from a vision standpoint or what's really supposed to be happening, it helps clarify how we can go about solving it. We've done a lot of stuff, as Barry mentioned, with respect to lean. There are a lot of books on lean. It's been around for a long time. It's become very popular in the last 15 or so years. But one of my favorite books is the one called Toyota Kata. And it talks about basically having a vision of where you want to go. And those visions aren't necessarily one of these 50-word, 100-word, large paragraph kinds of things. They can be fairly simplistic going forward. But the whole long and short of it is some place that you imagine we're going. And I've got some of that I'll show you later on. But an admission that we don't know how we're going to get all the way from here to there. What we can do in most cases is look a little ways down the road to what we call various target conditions, make our way there, and then take stock of where we are, reset the compass, and go to the next target condition. And over time, with a certain amount of patience and discipline, we can make our way to that vision. If we think about this going on right here, information delivered healthcare, you think about, as Barry said, lots of analytics, lots of, quote, big data, aggregation of data outside of our 4 walls. We're spending a lot of time just pulling the data out of our existing systems into a place that we can analyze, use, and understand. But it's at the same time, how do we get the pharma data? How do we get the lab data that was ordered by somebody else, somebody outside of our organization? How do we put that in place so that we can use it? For two reasons. For populations of patients, all the diabetics, all the hypertensives, we want to know what works, what doesn't work. Best practices can be distilled from that, a lot of research there, and the more records you have, the easier it is to find the signals and the noise. So that's one of the big reasons that this aggregation of data can be so powerful. Then we want to be able to take care of the individual patient. And that's where you want to know as much as you can about somebody and not redundantly repeat tests and do everything else, some of which involve radiation, certainly many of them a whole lot of cost. How can we find out everything that we need to know about Mary Jones, who happens to be a diabetic, at the point of care, in my native workflow, whether I use NextGen or Epic or, heaven forbid, paper? In any event, what can how can I have that information at my fingertips so I can provide optimal care? Or to the care manager, or somebody else working at the top of their license, taking care of the patient at that point in time. So you need this data, two big purposes. How are we going to make that happen? And I don't have all the answers to it other than it's going to require the accumulation of data. It's going to require some sort of stewardship. And some of you may have read the announcements. That could be CalIndex. I have some trouble seeing how we're going to get from here to CalIndex, which is basically a community health information network at a statewide level or a statewide HIE. We will see. It's got a whole lot of participants involved, but fundamentally that kind of concept may be the way that we can do these two things. We do live in a state, we live in a country that can't really sort out its identity management. That was supposed to be part of HIPAA, don't have it. This state here is a little schizophrenic on whether it's an opt-in or opt-out state, so you got to be really careful and not take on undue risk in terms of disclosing things accidentally. So again, we got policy and other issues along with technology in the way. This is the patient, in this case, Jane Smith, visiting these various clinicians, and it's all about this data that's being generated while this patient's being seen, going into a place so that it can eventually be used by the clinician going forward. And so this is the population health data warehouse. Again, this is an imaginative kind of thing. CalIndex, for us it's our Epic system plus all that we've augmented it with. But on a go-forward basis, we have to get information from all of these various sources, many of which are outside of our organizational boundaries, if we're going to take on risk for this population, for which we're not going to get fee-for-service. It's going to be more capitated. It's going to be managed care. Again, we're kind of 50-50, but as we navigate that fine line, we're going to have a way of moving forward. This is sort of an arbitrary view from my point of view where the perimeter is. We got the EMR, we got a lot of the hospital data, not all of the hospital data, but sort of where our footprint is today. That has to move out, or we're not going to be able to do the things that we need to do. This is Vivity, and I'm quoting the advisory board here, betting on coordination over competition. And why do we do these kinds of things? Well, another advisory board thing, we do it for the sake of scale, we do it for the sake of scope, and we do it for the sake of reach. We're working our way to the right over a period of time. And as Barry mentioned, we spent and have spent a fair amount of time on the left with shared services, trying to internally outsource, if you will, pull together those things that in some ways are sort of non-value add, but they're the engine of the enterprise, and economize on those things and share them across our organization. In fact, that could be a business unto itself if we chose to go in that direction. And then as we began to expand our scope, so thinking about us being more vertically integrated, being able to have more complete services, obviously brought physicians into our organizations, more nurse practitioners and others working at the top of their license, increasingly pharmacists and others with all the medication reconciliation challenges there are. So increasing that clinical scope, and then ultimately the reach, the geography, and not necessarily all because of mergers and acquisitions. It could be strictly people working together, and I think that's what Vivity is. The real question is, how are we going to move the data around? I had a number of questions at the break about how that will work. Don't know. We have some ideas about it. Vivity, as it starts out, the enrollees are pretty much contained within the various members. That's phase one. If this is at all successful, it's going to go up to where the members, the enrollees, have a lot more choice and freedom. If in fact it's going to be a really competitive accessible product in the marketplace, that's going to happen. And when it does, identity management becomes completely different. It has to work across the enterprise. And it could be offered by Anthem Blue Cross. Except, how do we plug something like that into Aetna? So we may have to have our own thing going on. And if CalIndex is at all successful, are we going to send everything up there, or are we going to want to concentrate that and cleanse it and make sure we have actionable analytics for ourselves as all of our member contributions, and then send that up to CalIndex? I guess the admission is we're imagining those kinds of things. That architecture is yet to be worked out, but it's going to be something like that on a go-forward basis. This is the comment I made earlier, and it's just an observation. I think this was from McKinsey. By and large, you know, the smaller organizations, many of us, certainly smaller organizations, have all of our data in silos and all the rest of it, but industries and others that pull their data together have a lot more leverage and competitive advantage. And unless we're swimming, so to speak, in larger pools of data, we're not going to know those signals in the noise. We're not going to really understand our costs to the degree that we're going to need to. Frankly, having a grocery store margin would be better than the margins I think some of us are having right now. We're going to have to figure out how to do things at much lower cost. I think the advisory board calls it price-based costing, where you step back and say, what's the market willing to pay? How are we going to adjust our costs to survive in this market? Someone's going to figure that out. Walmart's putting in clinics in all of their areas. What's that mean to us? $5 copay, $40 visits for non-employees. What's that mean? A lot of that's going to be data-driven. They have a huge advantage. While you're out waiting for your prescription or waiting for your flu shot, you can shop a little bit, buy some garden hoses, and otherwise keep the margin going. They don't have to make any money on it. That's not our business. What does it mean to us on a go-forward basis? We call that disruption, big time going forward. This is, I think, a Gartner slide here where it's talking about providers and payers. Let's face it, we're kind of invading each other's space. That's not necessarily a bad thing. That's normal business. Anybody who's growing, especially publicly traded organizations, has to find a way to grow into adjacencies. And Optum, a wholly owned subsidiary of United Health Group, maybe an independent company at some point in time, has bought physician IPAs in our market. So they have this vertical integration in mind as well. It just happens to run into some of our vertical integration. And the real question is, with the likes of Vivity, you know, it's a collaborative effort going forward, and it's yet to be worked out. To understand the payers, and I think you all know this, some of you probably from the payer community, they've been used to working with big data for a long time. They've had claims coming in from all sorts of sources about their members. They know more about our patients than we do, and they only have the claims data. The Aetna CIO told me in a recent conference, we can hardly wait to get access to that rich clinical data. And I'm thinking, okay, well, before we give away the farm, let's understand what the quid pro quo is. We'd like to have access to those rich rich claims so that we can understand all of our business. I think we're going to see that here, and I think we're going to learn to get along. This reminded me of, you know, we had the Cold War, you know, when the payers are the bad guys, we're the good guys, and until Putin came along, that was working out. But it was like Soyuz, you know, we said we were going to have to get along, so we sent up a rocket, they sent up a rocket, they managed to join forces. I'm not saying Vivity is anything like that, but it reminded me of when the game changed and when we said we're going to have to think differently, the Berlin Wall came down, all those other kinds of things. It's a step in that direction, and as I said earlier, I think we're finding our way through it. So I'm going to fly over these, I think, 9 points here, some varying degrees, to give you just sort of a sense of what we are and then and what we're trying to do, and frankly how I'm trying to add value to our IT functions going forward. And CEO said that's very important, so I'll make sure we're adding value. So let's talk about meaningful use. I'll only say that, you know what, it maps to population health. So it's a nice rebate on the investments many of us made, some of whom may have justified their investments on meaningful use. There was no meaningful use when we started. We felt it was the right thing to do, to go from paper to paperless medicine. Frankly, we had a mainframe ER. EMR literally was that we needed to replace. But it so happens those things that we're getting the rebate for do map to population health. They also happen to be very hard. So they're worth pursuing, and again, the advisory board's done a whole lot of work in this area. But as David Blumenthal said to a bunch of CIOs back in 2010, you're going to share data. whether you like to or not. Figure out how to do it amongst, certainly within your organizations and with your competitors. It's the right thing to do. It's the only way we're going to take costs out. That's what HIEs are all about, and we all know that they've worked to varying degrees. It's what CalIndex, I think, is aspiring to. But as the government says, and they really do have a lot of the power, we will use all the levers at our disposal to see to it that you somehow work that out. And we're struggling with some of our meaningful use stage 2 requirements where non-staff physicians on our staff, but not on the inside, not on Epic users, from which we get a lot of referrals, 50% of them have to get a discharge summary in any means. You can send them a fax. 10% of them have to be electronic, at least. And if not, you're not going to meet meaningful use stage 2. We're now in that phase. We're just north of about 12 or 13% on the electronic and about 70% for the 200 or so providers that now refer patients to us and to whom we need to send back the discharge summaries, the continuity of care documents, and the like, and we use a SureScripts tool for that. It's worked out very well. This is Francine. Francine was patient number 1 with Care Everywhere. For those who have Epic, Care Everywhere is basically baked in HIE. And Talbot Medical Group was one of our independent physician groups, now part of Healthcare Partners, now DaVita. In any event, they happened to have Epic. They had Epic before we did. And so we were going live with Epic at Long Beach. We'd gone live with Epic at Saddleback 2 years later. We're going live at Long Beach. And Epic was saying, you know, can you try out Care Everywhere? And we said, sure, we'd like to do that. So this was the Epic team that Judy Faulkner, CEO of Epic, sent out, and everyone's standing around waiting for something to happen. There was really nothing to do. We turned on a switch, and Care Everywhere, now called Care Epic, was ready to go. And within hours, Francine, a Talbot Medical Group patient, was admitted. The physician happened to have his camera with him. Francine said, okay, you can take my picture. And so she was the first patient that ever had Epic's Care Everywhere work. So I forget the doctor at the time, but was able to reach into Talbot Medical Group's Epic EHR, EMR, and pull the relevant data into our instance of Epic for the care that he was providing for Francine while she was in one of our beds. It was really pretty cool, no extra work involved, and that's the way it should be. He happened to know the patient was there, so you'd have to get in all the directory services and the other challenges that we have when the patients just arrive randomly, but nevertheless, a first step for us. Now 760,000 patient records are exchanged every month in the Epic world, and not just with Epic. That's Epic to all scripts, Epic to Cerner. It's happening from Cerner to Cerner and others, but this is becoming sort of the standard, a community standard going forward. And again, it's what David Blumenthal said you're going to have to do, or forget about your incentives for meaningful use. There'll be penalties after that if you don't. This was what our HIE looked like in June of 13, so 15 or so months ago. Fairly straightforward. Underneath this is our InterSystems Health Share product. We have their Ensemble interface engine and their other HIE like components. This is what we use. It's our main tool to be able to exchange data with others. And over the last 15 months, it now looks like this. And so lots and lots of wires, lots of data moving every which way, but we're able to send discharge summaries to Monarch. We're sending discharge summaries to Greater Newport physicians. We're exchanging data with Hoag. We're exchanging data with OCPRIO, moving things back and forth, starting to move the data around. So far, so good. There's probably something like this in our future with respect to Vivity. It's a work in progress, but you got to have these tools and you got to have identity management to go along with it. We spend a lot of time, this is topic number 3, sort of patient engagement. This is our brochure to entice patients to get a MyChart, which is Epic's portal, to, one, get the results, to be able to transact, schedule appointments and the like. It's really pretty cool, and it really is an advertisement. If you can get 10 to 15 to 25% of your patients to really accept these things, get engaged with them, it's really a good thing. It does make a difference in population health. Kaiser does this really, really well. Their Thrive program has to be one of the best marketing programs ever done, and their use of MyChart is really pretty cool. We're trying to emulate that and doing it with Epic as well. This is our number of active MyChart accounts, we have to drive these numbers up because that's part of meaningful use stage 2. We do a lot of that discharge. We create a MyChart account. We give them the log on. And some number of them actually stay engaged. And when they go back into the community and are seen by a physician that uses Epic, that data is already there. If they end up at a Kaiser facility, if they go to UCLA or Cedars, another Epic community, they can easily reach into our system and get information using Care Everywhere. It's really, really pretty cool. Problem is we got more than Epic. We have NextGen and our neighbors at UCI with whom we're partnering, for the moment anyway, have all scripts. So our patients potentially have 3 portals. And in one portal, they may say, oh, yeah, I've got hay fever. In another portal, they have a pen allergy. And then in another portal, they have latex. And what we really need is a universal portal. And in spite of all the requirements and all the interoperability and everything else coming out of ONC, those portals are not interoperable. Those portals are strongly tethered to the vendors. That's a competitive advantage for them. There's nothing really wrong with that, except from the patient's viewpoint, how do I move it around? There are folks in the market that say they have a universal portal. We haven't quite seen one that's going to be able to fit. We think we can maybe take the MyChart product down to its atomic parts and maybe reassemble it as some sort of more universal portal. We don't know. It's an ongoing discussion that me and some of my Epic CIO colleagues have with Epic, and it's one I think we should have with Cerner, Allscripts, and the others going forward. But it's one of those challenges that's a barrier, if you will, between here and really fluid population health and getting patients engaged. I love quadrants. Gartner makes good use of them, but there's a guy named Clement Chen who I think may still be with SAIC, pretty bright guy. And the Chime Focus Group was talking about patient engagement and, the kinds of things, the motivations that'll get a patient to really, truly be engaged. And he just put things in like 4 quadrants. He said, well, you got myopia, you got asthma, and you got hypertension. And for the person with myopia, the motivation's really high. I can't see. I think I'll go get a pair of glasses. And the amount of behavior change, not really hard. Just go put on a pair of glasses and so on and so forth. No problem getting the patient engaged. With regard to asthma, patients are usually uncomfortable. Lots and lots of motivation, a lot more behavior changed. There, we can usually make pretty good progress in that area. And to some degree with hypertension. Again, people don't usually feel their blood pressure. Anyone who tells you they can, they're wrong. You can't. You might feel tense and whatever. Your blood pressure may be high, but you can actually feel your blood pressure. But people increasingly understand that it'll affect your life over time. And we really ought to do something about it. And the behavior change is relatively small, except for the side effects associated with most of those medications. But by and large, you can get engagement. For the lower right, to some degree what Barry was talking about, that's the challenge. Coronary artery disease, diet, exercise, all those things none of us want to do. And you could also include saving for retirement. Humans are not very good at a time horizon beyond, I don't know, Saturday or the end of the month. The challenge is there's lots and lots of benefit in intervening here. There's a slide I'm not sharing, but the advisory board does a good job of talking about the rising risk. There's chronic disease, and there's all those kinds of things that we need to deal with for those patients who 20% of whom are consuming 80% of the costs. We need to deal with that, no question about it. Then there's the next tier that don't yet feel sick, may not even know they're sick. In any event, we call that the rising risk. They're in your population too. How do you get to them to avert or otherwise delay the disease that ultimately all of us are going to get anyway at some point in time if we're lucky going forward? But how do you avert and defer those things and engage them going forward? Gartner slide, another one that kind of highlights it. It's happening slowly but surely. You smoke, you're going to pay more. You don't diet, your BMI is too high. Sorry, you don't get to be in the narrow network, or if you do, your monthly premiums are slightly higher. That's a very hard thing for us to do culturally, but you're starting to see evidence of it. And when there are economic incentives, when there are those kinds of things in place, behavior changes. And when they're not, they don't. So I think we're starting to see some of that creep into our plans, certainly for our own employees. Barry said it well. We really want them to be healthier. They will be more productive. They will be happier. They will live longer. And yeah, they will cost less. But the bottom line, they'll be more productive. They'll be a stronger part of our team as a result. We're trying to figure out ways to motivate them so that they understand it's in their interest as much as it is anyone else's interest to get engaged. all right, so I got a data warehouse. I'm not spending lots of time on analytics other than to say it's pretty complicated. We assemble the data. I had a different slide that kind of shows this data being sucked in from all our various transaction systems, and it goes into this magic milieu. And we spent a lot of time, and you may be reading about, data governance, master data management. When I first heard those terms, I'm thinking, oh, come on, what's that all about? Why just put it in there and run some SQL? There's a lot more to it, because just ask somebody what your census is or what it costs to do this or that. Finding a single source of truth with multiple sources of data, kind of hard. And when you're down to low margins, you need to know for sure what you're talking about. And so this is a lifetime's worth of work, but a fair amount of work that we're experiencing right now is to pull this data together and organize it in a way so that, one, we can understand it, and secondly, we can make it accessible to the organization. We like the SAP tool. So behind all of this is a schema. Pick a schema. You can buy a schema. You can develop your own if you have the wherewithal to do it. But by and large, you need to organize the data. But what you really need to do is to put it together in universes of various kinds and expose it to the organization and allow the people taking care of patients to take actions based on what it tells them. And so we're in the midst of that with dashboards and other kinds of things on the right. We also have 500 or so standard reports we can run out of Epic. We're trying to use our lean practices to narrow those things down to have a smaller number of more comprehensive reports. But that said, those are the ad hoc. Those are the routine. Those are the things we need every day to manage the business. Then there is, at not too distant future, all of that data together to be able to analyze going forward. But the really hard work is first gathering it, secondly organizing it, master data management, coming up with real definitions of what a census is at midnight or some other point in time, then starting to make it available to the organization in some fashion or form. And I think you really arrive when you can actually have a few people who can fish around in the data and look for things, what it might tell you. Big data, I'm quoting somebody here, but it's really about the volume, velocity, and the variety of the data coming at us, and it's phenomenal. You go listen to some of these other folks that are collecting data from hundreds and hundreds of sensors, the quantified self, if you will. What are we going to do with all that data? And whether we consider that data relevant at this point in time or not, the data generating devices are growing in our midst. There's probably some value in all of that, and as there's more and more of it, you assemble it in this, quote, big data thing. And if you imagine other organizations coming together, let's say us and the other 6, I guarantee you our first work, and even amongst Epic clients today that are different, just getting our data together and define it in the same way is an enormous amount of work. And so that's sort of job one. When you have organizations affiliating and not economically aligned, like Kaiser is, and I'm not saying their job is easy either, but it's easier than all of us trying to assemble our data and make some sense of it when we've used slightly different definitions. So it's the variety of data, the volume of data, the velocity of the data, the required technology. I'll talk about it in a second, but the high-end stuff, be able to analyze tons and tons of data and then connecting the dots. What does it tell us on a go-forward basis? We have 1.5 billion flow sheet rows in our Epic system. We're a mid-sized institution, been live on Epic since 2006. 1.5 billion rows of data, all the rows that are in there. 177 million orders. Everything that was ever ordered, it's all sitting in there. And 107 million results. And so Dan Exley is the guy that heads up analytics for us, been fooling around with SAP HANA, been loading these things in there. And some stuff would just not run. In fact, it just would sit there and finally all the reporting things would quit. Until we began to change the technology that we were using. Now it takes us about 45 seconds to process all of that. And these are really real things that we're doing. Sepsis is a big deal, right? Sepsis is one of those never events. You shouldn't have a sepsis. And certainly patients become septic, but it's not a good thing. Patients frequently die from it. Bugs and other things these days are increasingly resistant to all of our treatment mechanisms. Not good. So we're able to analyze the data and looking for sepsis. And what we're looking for in the case of lactic acid accumulates in patients that are pre-septic, where are they? What were all the events that led up to it? And so we're in the middle of that right now. we're at the point where we have enough data that we can search all of the drugs, we can search all of the various results to do these kinds of real business pursuits. And then this is, again, where we're on the threshold of big data best practice development. Sort of this virtuous cycle here, identify and focus on an area, begin to pursue the data, put it, these big, large data sets inside the SAP HANA engine, if you will, and define the semantic layer to get sort of technical from this point forward. But the underlying theme going on here is analyzing this data, looking for what worked, what didn't work, what was associated with what, where do our best practices come from. Again, best practices exist out in the community. Best practices certainly exist in the various disciplines. They also exist within your institution. And in some cases, you need to make your own choices about how you're going to approach one form of care or another. So again, this is what we're doing right now because we've accumulated tons and tons of data, and I expect we'll be doing these kinds of things in partnership with the 6 other institutions once we begin to pile our data together, and we should see things sooner than we would otherwise. Kaiser saw the impact of Vioxx on heart attacks before anybody else. 8.5 million members, they began to see, that while this may be it was an ibuprofen, a Motrin-like analog that seemed to cause blood clotting and therefore heart attacks, said, whoa, we need to stop doing this. The FDA now uses them because they tend to see things much sooner than everybody else, as does Cleveland Clinic and others. We're on the threshold of that ourselves, where we can begin to see these kinds of things and make new insights. And this is what I think is coming next, is all the genomics. There's a tab already ready to go inside Epic for your genomic profile that increasingly is going to say what drugs will work, what drugs won't work. In the case of Plavix, some people it just doesn't work for. And that little chart on the right is about, dosing things. I got my start in DP because I was programming those charts on an Apple II computer looking for, in this case, we were doing gentamicin or theophylline drugs that have a narrow therapeutic index. That is, the amount that you need to help you is the line at the bottom, and the line above which you become toxic is the red line, and the closer they are together, that's called a narrow therapeutic index, you better dose in that area, because below it, you're not going to have the effect. You're not going to knock out this bacterium. Above it, you're going to make them deaf, or you're going to knock out their kidneys. And so typically you have a sawtooth. Well, there's one, the choice of drug. Will it work at all? Why put them on a narrow therapeutic, why put a patient on a drug with a narrow therapeutic index if it's not going to work? And increasingly the genomics are going to be giving us insights into that. And the things that are on the horizon that we're not quite there yet that I've heard some of my colleagues talk about is while the patient, or while the clinician is seeing the patient live right now, can we look far enough back in our data so that we can say, for the last 100 patients that were just like this patient with regard to general age, gender, comorbidities, and so on, what worked and what didn't work? That's the frontier. That's where we need to go, real-time query, so that we can make the best choice for that patient while they're there, because that's the time, the best time you have to make an intervention. That's where this big data is going, and there's lots and lots of data. You need powerful tools to make it work. And I think we heard the question, will we have all the workforce that we need? This was, again, from McKinsey forecasting the need for data scientists. And it says, basically, by 2018, good luck. We're not producing enough of them, and there could be a shortage. So Barry mentioned the nursing training program. Dan Exley recently recruited 2, they were grad students, but they were out of Cal State Fullerton, sort of the, I want to say bright empty head. They were relatively new in their career, smart kids, they're kids. And they had analytics, they had engineering, they had some other stuff. We're training them. And man, oh man, are they running fast. And so we're seeing this down the road. We're going to need people to play with the data going forward. But we are forecasting it's going to be a challenge, much like the nursing shortage going forward. There's lots of information inside that data. You probably have all heard the story about Target, who figured out the young girl was pregnant before her dad did. If you haven't heard about it, go Google it. It's a very interesting story. It was all in the data based on when she shopped. What she was buying at Target. So data scientists sitting in New York figuring that kind of stuff out. Managed care. Epic Tapestry is a very complicated, very powerful tool. if you're going to take on risk, you're going to need those kinds of tools going forward. This is an integrated product with Epic, used by others that are beginning to take on risk. As we have an HMO, an ACO, we're beginning to use this to adjudicate claims. Barry mentioned Seaside Health Plan. We're not intending to compete head-on with the payers, but with managed Medi-Cal and others, we see that as a capability we're going to need. So we're marching into this space, a new frontier for IT, in some ways very complex, harder than the EMR. So just to mention, this is McKesson Risk Manager. We bought that first. Actually, at the time we were rolling out Tapestry, but we were in the early phases of Tapestry. Some of what we're doing with Epic and Tapestry is leading. We're right up there with all of Epic's clients and moving it into California managed care-like programs. But we did buy, was known as MedVentive and then now McKesson Risk Manager. This was another company in which we invested. So that's ended up being free when you look at it in the grand scheme of things. To MemorialCare, we're using it now for utilization management, risk stratification, P4P, and other kinds of capabilities in that space. And the question now is it going to be displaced by Tapestry? In all likelihood, yes, at some point in time. There's a Crimson product that works in this space. There's a Crimson product that we have on the inpatient space for utilization that we really like. Again, sort of point solutions going forward. So it kind of looks like buying these point solutions back to best of breed for a period of time and maybe for some significant period of time as we sort out what our real requirements are. But you definitely need these kinds of tools. So let me just talk for a second about how we do our IT planning. This chart I used, I think, when I taught at SC a while back on sort of IT, but you've got the IT plan, which largely a derivative work, stemming mostly from the business plan. The business plan itself being driven by the environment. And also being, I hope, to some degree, inspired by technology. So it shouldn't be that some technology comes along that we should absolutely adopt it. It should be somehow connected to the business plan. But you may have your business shaped to some degree by what's possible. Apple's Health Kit, for example, is a tool, not a solution. And it might be something that we might want to incorporate into our business plan, not build our business plan around it, but it could easily stretch our business plan into a new dimension. So and then you have your current systems, which we've, as I said, rationalized and now almost de-rationalizing as we buy those point solutions to augment our population health capabilities. And then we use our lean management system. Continuing to rationalize how we do our various processes. That gets translated into Epic optimization. That gets translated into lots of activities for us to use and exploit Epic further. I just, rough estimate, I think it's 80% the IT plan is driven by the business plan and maybe 20% inspiration coming out of technology. Probably should be something like that. It suggests that you really should take a look at what's going on out there and with these vendors and others, what they're doing at the margins. It's not all about the big vendors. There's a lot of innovation going on out there with the smaller vendors. Pay attention to that. There could be some disruption in your future. My friend, colleague Darren Dworkin talks about, take a look at Uber. Who would have guessed that the smartphones and everything else could disrupt the taxi business in some way? And look what's happened. So some of it's obvious, some of it's not so obvious. But there's disruption in your future. So I think somehow it, to some degree, can disrupt or at least inspire your business plan. This is the way we look at it on a go-forward basis. Come back to the hype cycle. This is the hype cycle for consumer engagement. I use it only to illustrate a point that Gartner, and I'm not a Gartner guy. I'm not here to sell Gartner or a commercial. They're good thinkers. They run pretty good radar. I need their help. They think about these things in really, really creative ways. They take all those things on the hype cycle and they plot it as to its impact, as to transformation, low to high on the left, and how long it's going to happen, from left to right on the top. And that kind of helps. Those things that have minor impact are going to take a while. That's actually an empty box. So not really too much to pay attention to. But you take a look at the upper left. Those are the things that are either through the hype cycle or coming out of the trough or moving quickly. Those are going to become table stakes. Your competitors, your partners, or others are probably going to have them sooner rather than later. This is where you might want to also look as to what's going on to kinds of technology, because these things are moving slower or they're earlier in the hype cycle. There's more risk, but if you figure that it takes 2 to 7 years or so to move through the hype cycle, if you pick well in this space, there's opportunities to have differentiation because you're going to be ahead of the curve. Again, I'm not saying you take undue risk. I think you just need to take a look at it on a go-forward basis. When we look at it, and I just sort of borrowed from, the financial planner guy, think of your IT investments and the stuff that I asked Barry to pay for as sort of a portfolio. Let's invest and augment what we have, sort of low risk, table stakes, healthy visits are a big one for us. We got to do more of it. No question about it, off to the right of Gartner's cycle. But then there's the stuff in the trough that is like heading for no man's land. At the peak of inflated expectations, just before that, that's when the guys, and you all know, the gals come into your office breathless, wanting to get something. And it's just a solution they absolutely have to have. And then you get to the top, other people are doing the same thing, they begin to slide off because it doesn't work, and then they're gone. It's like, whose idea was this? And sort of work through that. But in there are things that are going to work. And so maybe 5% of your stuff, or 5% of what you might consider maybe is on the left, 15% of stuff that is showing some promise but is also starting to not work in some areas. But in there is going to be a whole lot of learning and maybe some survival going forward. So where do you set the needle? And where do you pick? And it's not like we have lots and lots of surplus money and lots of surplus resources, but much like your portfolio, you want a little bit of small company, a little bit of overseas, a little bit of commodities. You want to sort that thing out along with your big investments in your dividend-paying stocks and the like. This is the zone of potential competitive advantage, if you will. I like this quote from Roy Amara. It's been said in different ways. It's not Bill Gates' quote. He said it first, back in the 60s. But we tend to overestimate technology in the short run, and we tend to underestimate it in the long run, or overestimate what we can get done in a year and underestimate what we can get done in 5 years. So picking and choosing is part of, I think, the CIO's job these days, because innovation is working its way into your area of responsibility one way or the other. I like this from Becker's. It basically says, us being sort of risk-averse types, IBM and Apple are going to own healthcare because no one ever gets fired for buying IBM. No one these days probably gets fired for buying Apple, or for that matter, I suppose Microsoft Office and so on. And the whole point is kind of knowing that disruption is in your future and that you might want to look a little bit to the left. It's not an argument to not buy Epic or Microsoft or whatever safe, but to consider it in sort of your complexion or your portfolio of IT assets that you have a chance to differentiate by picking and choosing people that can somehow apply not necessarily new, but existing technology in creative ways. So part of your job as a CIO is what I call creative assembly, going to fries, if you will, picking a bunch of little things that anyone else could pick, putting them together in a way that someone hasn't thought of, creative assembly, to solve a business problem that everyone has and that someone else may actually be trying to solve as well. Your differentiation may be in how you solve it relative to them. And if you somehow be clever, smart, and inexpensive at it, you're off to the races. In any event, you're solving a business problem. So it's mixing that up and deciding how it should all fit together. I thought this was a great Gartner slide to think about. Again, hey, these are good questions. When will our telemedicine monitors and so on really make a difference going forward? How are you going to have to think about this going forward? When we put in Epic, we did some really crude measurement, and nurses were spending about 38 to 40% of the time documenting things. And we were pretty sure that when we put in Epic, we would have some wins there. In fact, we even, part of our ROI was banking on having some improvement. And it turns out we're still spending about 38 or so % of nursing time documenting. The good news is it's legible and it's accessible. The other good news, we haven't gotten there yet, there's information embedded in those notes. And just, the Watson, the IBM, and the others are all about mining those notes for clues as to readmission likelihood and a whole bunch of other stuff related to social factors. Those are inside those notes. So we think that really, really matters going forward. But we haven't exactly disrupted, if you will, the nursing charting process to increase more face time. that's still a work in progress. There are instruments all over a patient's room. Those of you who've been out and on the floors and seen the intensive care unit, poles, IV poles, tubes, wires, things everywhere, a wireless environment. It's scary. Those are typically data-generating devices. What are we going to do to make the nurse's life easier and pulling all that data together? That's a work in progress for us on the acute side, which fundamentally is a big part of our business in perpetuity, along with everything else going on the outside to make that inpatient stay safer, better outcome, less likely for sepsis and so on. In many cases, that's going to be data-driven. These are the kinds of questions that should trouble you in some way, or at least inspire you to think about, yeah, okay, beyond the EMR, what's next, and where am I going to lead my organization? Keep an eye on what the HIT investment community is doing. These are, with the smart, there's a lot of money out there looking for a few good ideas. And as we in the MemorialCare Innovation Fund begin to look at ideas, we can take 100 ideas, be lucky if we get down to 10 that, yeah, they seem okay. Get that down to 5 that aren't bad. Get it down to 3 that have high potential. We're lucky if we have 1 or 2 in which we might, sink some money. And we're not a passive investor. If we're going to do that, we're going to probably want to use the system. Otherwise, we might as well just, give the money to the treasurer and let him go invest with Fidelity or somebody. We actually want to use the products. We're a great laboratory. That doesn't mean experiment unduly or with high risk, but to try to innovate, to try to disrupt our current processes. And so pay attention to where this money is going. I think it's unfortunate, but if you go to HIMSS these days, you're on the vendor booths, you're stuck in the middle of them, you can barely see the margins of it. The margins, those are the cheaper booths, are where you're going to see, I think, a lot of the inspiring kinds of things. That's why I think this kind of affair is really important. You can see people that are probably, maybe in one of these boxes out there, and in there, maybe an opportunity. Barry mentioned this. I'll say it explicitly. We in Cedars have put our innovation funds together. It's an $80 million venture capital fund looking for good ideas. We're both laboratories. We've invested in 4 things so far. Prior to that, the MemorialCare Innovation Fund, we did MedVending, we did Care Team Connect. We're running 3 others right now, looking for some ideas. We think it's really pretty cool, and we think it's a measure of disruption. It's a way for us to, again, not experiment, pilot some of these kinds of things and welcome the vendors into our organizations. It was something we felt we couldn't do alone, that we better just do it with others, and so we have that underway now. It's really pretty exciting, and it's where I spend part of my time these days. This was Epic, so I'm going to talk a little bit about optimization. So Epic was, and this is just my crude metaphor for it, but Epic was like this sphere that was so big when we started. They were in a schoolhouse. I don't know anyone who's an Epic client or have heard about Epic headquarters, but it's not a schoolhouse anymore. It's multiple buildings, auditoriums that hold thousands of people. It was a schoolhouse. But the surface of that sphere was pretty much, you could work your way around, you could build all around the surface, and we did that. 16 design, build, validate sessions over 26 months. We went live with Epic, and we did a pretty good job of it. Now Epic is on the right. We can barely keep up. That's an exponential function, by the way, the surface area of that sphere. And the good news is Epic is producing, and they're marching into population health. So good stuff to pick from. The question for us is making choices, what we need next, where we're going to go with it, and how to exploit all that we have going forward. These are the things they've released. These aren't all of them, but year after year after year after year, these things come out, and it's like, man, I just want, how can we get to this stuff? Dual monitors, cool stuff in nursing to where you can swing a session. A physician's got his or her iPad in a patient's room talking with a patient. Let's just swing that session up to the TV in the patient's room and interact with the patient. Let's bring up my chart. It's all possible with the technology we have. We need a few more resources to get them all done, but the good news is we have this onslaught of opportunities coming forward. And when Sabula and I were planning a lot of this stuff going forward, I said, I want to make sure we don't overbuy and underutilize, which we've done in the past. And it's got this growing gap of this stuff coming at us from Epic. And so our challenge is to, and being early with Epic was a good thing in some respects. But since then, they've developed a lot of foundation work. There's a lot of shelfware. If you go by Epic today, you practically can just, there's a lot of customization to be sure, but it's a lot easier to install. They do it in a shorter period of time. It's a more standard kind of build. We're kind of digging out. So the good news, we were early. Bad news is we're kind of affecting some of the changes there, so our optimization to some degree is driven by getting to a more standard Epic going forward. But we want to make sure that we use all that we have at our disposal. It's not always about buying more, Barry. Sometimes it's a matter of using more, so I don't necessarily need capital. Sometimes I need more resources, labor, and frankly try to avoid, I promise, Barry, no more labor. We are going to get better, and I'll talk about how we need to get better with the labor that we have. But frankly, we have a lot of tools at our disposal, and this is just a reminder and a graphical way to display and frankly to convey the challenge we have at closing the gap of optimization going forward. You cannot be too good at governance, project management, project intake. We're okay. It is an area of intense work for us right now as we've been sort of rationalizing some of our intake stuff. There is so much we can do and lots of opportunity. I mean, 2 or 3 things that came up, our imaging centers and the like have arrived somewhat suddenly, and as you might guess, they have different systems, and somehow we want the patient experience to be somewhat uniform. How are we going to do that? So it's not always planned, but you don't want to miss an opportunity at the same time. So we've spent a lot of time getting to a web-based application or project management portfolio. We've been counting projects for things that move us forward, things that are really just keep the lights on and so on, and measuring those kinds of things. So on a go-forward basis, the problem is, we've been graphing this, the arrival rate of things to do is exceeding our ability to retire them. And so we either have to expand the pie of assets, resources, get smarter at how we do it, say no to a few things, be more discerning. So it's a combination of all the things going forward, but it starts with understanding what's coming at you. And at our size, at $3 billion, is kind of beyond our reasonable comprehension. We can't just do it on the back of a napkin anymore. We need some more powerful tools. So we're gating the intake process. We have great ideas. How do ideas make their way to something that we feel better about? How do they make their way to something we feel should be truly considered? And then how do we plan for that, and where do we insert it along the way? Do they get to the back of the line? Do they go to the front of the line? But even just evaluating the ideas is a resource-consuming activity. And frankly, we don't have a lot of people on the front able to do that. Recently, I lost a VP to an area we call business integration. We now have somebody whose function it is to sit out in front of the organization, with the people at the front of the boat kind of looking at the opportunities coming at us or things we want to pursue, and looking, amongst other things, not only the cultural fit, the business value, the synergy that's possible, but also to understand what's it going to take for IT. And so this gal who helped us roll out Epic has got a good sense of the IT assets at our disposal, our technologies and so on, who can help us accelerate absorbing, if you will, embracing that new organization or function into our organization. But that's a work in progress as well. These are queued projects, and again, it's a matter of just what gets measured gets managed. An old famous Drucker saying, I think it's absolutely true. I'm trying to come up with this other metric. I just want a simple metric. What's the ratio of planned to the unplanned plus planned? And can I get it as high as 75%? It's not 75% right now. The unplanned is a little bit too high. And so I think part of the problem is we're not IT. I'm not running my radar as well as I should. I got to get farther out there. We can't be too connected to the business to smell out the ideas. And, talk with the CEO of Saddleback who's thinking about something. We need to hear it when he's starting to think about it so we can begin to anticipate. We want to drive that planned thing up. And we do that via our business planning, things that make it into what we call our strategic pyramid, for which there's an IT component as far out as we can, so that when they're planned, we know about what they're going to take, we know what they're going to cost, we know when they're going to start, we know when they're going to end. I'm here to absolutely tell you and admit we're doing better at this. We need to do a whole lot better if we're going to manage our resources going forward. This just showed up in my inbox. I like McKinsey. I don't know, I've heard of Bob Solo before, but he said when asked about productivity, and I don't know about you, but I don't need any more tools. I've got a smartphone, an iPad or two, PCs of 2 different varieties. and my email still disappears. I mean, we're almost at our limit of productivity, and I'm sure that people taking care of patients and others feel the same way. You know, what's really going to make a difference? And what he pointed out, and some of which for which he won a Nobel Prize, so he probably had a few things right. A lot of it comes down to managerial decision making, making good decisions and fewer not so good decisions. But the other thing he pointed out is when management really gets good and when people really get good is when there's competition. When you're a monopoly and there's no competition, you're kind of lazy and fat, and it's like, you know what, I think we kind of knew that, but here's the evidence to back it up. And I'm not saying that we're in this competition. I like to think healthcare is more of a collegial sport. Anything else is flag football. It's not the stuff with helmets and everything else. But nevertheless, it's a game and an exercise, and we'd like to win. Part of that winning is the fact that there is another team on the other side that trying to do the same thing. So we in Anthem are going to work together with our 6 partners on that Vivity, and they want rich clinical data. We want more claims information. We'll see how that goes. But that competition or the threat of, I suspect, Aetna and Blue Shield with similar ideas out there that make us sharper, I think, and a little more disciplined, and maybe make a difference going forward. I had to share this. One of the first things I did in the DP department after finishing all that Apple work was work with this gentleman who's now 94. He's the father of treadmill testing. He wrote books before I was born, discovered stuff about ST segment depression. It has a lot to do with prediction of whether you have coronary artery disease and the like. But I found this article. We were cleaning out an office. He's still with us. In fact, at 92, he stopped doing treadmill tests. Thought that was probably a good thing. But he's a consummate teacher, to be sure. And he wrote an article in 1962. 1960. That was before Kennedy was shot. You know, missile crisis. You know, just after that. That's when this was being written. He said much, and I put the highlight in. Much work remains to be done before practical computer automated information systems is developed. But we are optimistic in our belief that a practical system can be developed using the concepts in their article, which I have if anybody wants, in our model, and that system will improve the quality of care without increasing cost to the patient. And I just had to share with you the diagram in that article. It's not far off from where we are today. The symbols are a little different. The Samsung dryer at the bottom is the CRT display. Now, they still use those every time you fly into LAX. There's someone in front of one of those things, and they're kind of watching you make sure you land. But that was their CRT display. But what was really fascinating is physiological monitoring instruments being digitized. Now, he recognized at the time we didn't imagine all analog being digitized. So he has his analog stuff, his voice. He still has a typewriter, considering a keyboard. But, you know, 1962, the idea of digitizing the physiological instruments and being really close to treadmill testing and all the rest, I think he did a remarkable job. So he still comes in, meets with us once a week up at our Long Beach facility. New gentleman's taken over the MemorialCare Heart and Vascular Institute. He's a really, really interesting guy, and I enjoyed our work with him. But we're still at it. We're still at it, and we're going to be at this for a while, I guess, is the main message. That's okay. This stuff is hard, and just when we thought we were kind of there to what Dr. Elistad said, you know, a computer system that can do a lot of the stuff without increasing cost to the patient. I suppose some of that epic cost got passed along, but we kind of got there, but now there's population health, so we're still continuing. This is, we're not quite there yet, and Barry and I had this conversation a while back, and I said, and this was just sort of intended to be thought-provoking, but thinking about it from a patient's perspective, you know, we promise that we will safeguard your results and make them available with all your privacy and everything else wherever you are in our system. And we're good at safeguarding things. I feel pretty comfortable with that, although that's one of the areas where I lose sleep at night, worrying about a breach, worrying about our data center reliability and so on. But by and large, you know, we need to make this promise. We need to make a promise that you're not going to be a stranger. And to some degree, I've been with the organization long enough to have knocked on a lot of the doors, and sometimes I'm a stranger there. I'm not known to them. And all right, that's a data point of 1, but it's not, if you believe in engagement and you believe in consumerism, which was woven into a lot of what Barry and I have been talking about, and high deductible health plans and so on, Yes, patients are going to shop on cost. No question about that. But they're going to shop on value. They're going to begin to shop on how you're treated. You know, as Barry said, United remembers who he is every time. And Hilton Hotels knows that I want a king-size bed on a low floor or whatever it is. And Vanguard always remembers me. We do okay with that. So as we are starting to do okay with it, what happens in Vivity when the enrollees can all move around? We need to do a good job of that if it's going to be really competitive, because if you think about who we might be competing with, I think they remember. And so that's our aspiration. That's our vision. We've got to figure out how to make it work. And then a pet peeve. We promise, if you filled out one of these intake forms, we don't want you to fill out another one. We're not there. I think, though, with identity management, I can imagine being a programmer years and years ago. It's really simple. But if we were to ask 50 of our PCPs or 50 internal medicine docs, give us your intake forms, I'm willing to bet a fair amount of money that 80% of it is common. And I know that it can be programmed, so to speak, a form that can be created. And then if you showed up and you'd been to one of our places before and we ran our identity management and noticed that, we could say, hand them an iPad and say, could you just edit some of these? You want to make sure it's still correct. And, you know, prove who you are and everything else. I think we could do that. I think we should do that. I think it's going to matter. I think customer relationship management is going to hit us. Salesforce.com is not chasing healthcare for no good reason. They get it. And so we have to understand their principles and apply them to healthcare, because it's not just us. We got to certainly, you got to leave our institution without infections, on time, with a hip joint that is right for you at a good cost. That's just got to happen. That's kind of table stakes. But it's the experience that's going to matter at some point in time, too. And I think you could be preferred based on that experience. So we're still at it. The slide that Barry talked about, the bottom line is IT operates in every one of these things. To the left, it's all about the things you all know about. We've been doing all day long. First and foremost, best of breed to organically grown systems, things like Epic now into population health, but only 20% of its real impact. The genomics and things like that in the middle, forget about gene treatment and everything else. I think that's on the horizon, but at least understanding your genome and what that means to your care is going to matter. There's some IT in there, a lot of research, new area that I've been paying attention to lately. And then over on the right, the patient engagement space. No silver bullets, no universal portals yet, but an area of huge opportunity. At least that's where the impact is. And there's a lot of social policy that needs to change. If you're not going to quit smoking, I'm sorry, you should pay more. If you're not going to do some of these other things, within your control. I mean, you have your genetic heritage, you have these other kinds of things, but where you can make a choice, then make a choice that actually leads to economic benefit. It's part of the greater good. You have a social responsibility here. So there's IT woven in there. That's a lifetime's worth of work. We'll be at that for some point in time. Most days I feel like the turtle, the tortoise. This is a muddle. We're making our way slowly but surely, and anyone who tells you they've got a prescription, listen to them. Either they're right and you should absolutely follow them, or they're not. I think it's more of a finding your way. It's a bit of a muddle. No apology. I think this is extremely complex. It takes teams of people to get it done. The requirements are not clear, and the business is not clear. It's a mess when you think about it. There's enough money in the system. We just need to figure things out. I happen to have been in the country of Chile, watching what they do with healthcare. They get, frankly, almost as much done as we do for about 20% of the cost. They don't have identity management problems. I've got this photo that I was unable to incorporate it here in enough time, but I took this picture overlooking an admitting area, and it looks like bank teller areas. And over to the right there, you say, what's that? It's a thumb reader. The identity management is fundamental to what they do. I had to buy a $1.5 million system for identity management so that I can make a guess that it's you. It's a good guess, but it's not 100%. The only thing Chile found out is that, when you get into your 60s, your fingerprints really aren't as good as they used to be, and so you may need more than one finger, or if you have a farming accent or whatever, you got to have a backup strategy. But use your foot or whatever. But by and large, it solves the problem. Well, the government wants us to do things for less, but they won't give us that help. So we got these challenges. That's why I think, to some degree, it's a bit of a muddle. And when in doubt, always turn to Yogi. If you don't know where you're going, you might wind up somewhere else. Let me just tell you that, and Barry can probably remember some of the quotes, when we did our EMR and our change management and our pharma model, so to speak, it was, I know we're going west, I know we're not going east. I don't know if it's exactly southwest or northwest, but I know we're heading west, and that's the right way to go. And we'll see what we encounter along the way. And so I think that's still true, and if I can narrow that to 90 degrees, you know, northwest, southwest, I think we're really doing pretty well. We've been doing so well, you know, reasonably well so far. I just did admission. Found another Gartner chart that said the same thing. It's like, you know, there's this prescription, we kind of go this way, we kind of go that way. No, you don't. Maybe some people do. There's truly these innovations that happen. They're the likes of Google. What Jobs did at some of the stuff at Apple truly was inspirational. Not normal, not common. More often than not, we kind of find our way. It's okay. I think you want to do whatever you can to increase your agility, get the most out of your resources. For us, it's a whole lot about project management. It's about growing the bright empty heads. I've had a number of vacancies for an extended period. I finally got to the point where I'm a little worked up about it. I said, look, a third of these people can come out of the local university. They're all over the place. And because there's been this tendency, well, we got to hire people with Epic experience. Yes, we do in some cases. But I asked, how many people did Epic hire with Epic experience? 0. We can do some of that too. That's how we started. So again, that's part of that finding our way going forward. So with that, I'll say thank you for your attention, and I'm happy to answer questions or find you during the break.
I think we can. Scott, we can take maybe 1 or 2 questions because we need to break for lunch. But I see an eager question.
Oh, no.
Ask her right over here.
Thank you, Scott. My name is Michael Arrigo with No World Borders, and I'm a contributing writer for HIMSS Media, including Healthcare Financial News. I would argue that a lot of the infrastructure that you have, and it was very excellently articulated, is similar for fee-for-service or for risk-based and capitated medicine. At the front end of care, taking on risk involves risk-adjusting patients and their comorbidities. I wonder what you're doing with clinical documentation at the front end, how much of that's IT, how much of it's clinical, and what the processes are, because it seems that ACOs and Medicare Advantage are going to be all about that risk adjustment.
Well, it's part of what we do with Medvedev and Tapestry is to basically stratify our populations into those with diseases and whatever that for which are consuming the most of our resources, understanding to some degree, again, as we're working our way through that and actually have populations, those patients and others for whom we should begin interventions, and the rest that are really normal and healthy going forward. But to your point about CDI, clinical documentation improvement, a work in progress for us, but we've been doing a lot of voice recognition, a lot of improvement. We think there's a lot of opportunity to do better there. That's really taking costs out and getting more complete and more accurate notes, a lot of coding as a byproduct. But believe it or not, this is where policy and practice gets in the way. If you do too much to aid a clinician while they're trying to distill down their impressions and other kinds of observations and measurements of a patient, if you lead them with, you're saying this and that, do you mean this? That's upcoding. It may not be upcoding, but it's translated by the government as upcoding, so you can only guide them so much. So that's where we are, is like pushing that frontier. We're working very closely with Nuance in that area. We see it related strongly to ICD-10 and trying to do all those things together at the same time. I don't have any magic formula other than to say we think technology, we've taken our transcribers and turned them into editors as much as we can, and we think at some point voice recognition in combination with tools will largely change that, and that's happening as we speak. There's always be a need for some of it, but that's what's going on there. That's a whole area of work for which we have a physician largely dedicated to help with that process. That's changing practices, which, by the way, the CDI activities depend a lot on the clinician. For a proceduralist, guys doing hips, completely different than the guy trying to do a workup on a patient with comorbidity. So the internist or the intensivist or the hospitalist seeing a patient, completely different experience, different tool sets, different CDI needs than the guy who's seen a lot of hips. So we're working on it. But as the CDI and those notes improve, we haven't gotten to it yet, we know there's information there. We know there's information that will tell us about, maybe retrospectively to be sure, but there's also a lot of information in those notes.
Let's give Scott Joslyn a round of applause.